So we can move on to Dr. Jay Sheth, who will be talking to us about pachychoroid.
Hi, good morning everyone. So first of all, thank you Anirudh for inviting me to be a part of this IC. And my talk will primarily be focusing on two cases where I feel I've had more misses than hits, and I guess I'll need active inputs from all the experts over here. So we'll straight away go to the first case. This was a 45-year-old lady who presented with decreased vision in the left eye of 1 month duration. Her visual acuity in the left eye was 6 by 36 N18 and 66 N6 in the right eye. Fundus examination of both the eyes showed presence of lot of tessellations with presence of serious macular detachment in the macular area in the left eye. Now the right eye multimodal imaging including the OCT, fluorescein angiography and the ICG was absolutely fine. Now we'll proceed to the left eye. Left eye showed presence of the serous macular detachment with presence of few underlying pachy vessels, and as Dr. Raja sir had pointed out, there was presence of a flat irregular PED which was quite shallow in nature. On doing an angiographic imaging, the fluorescein angiography showed presence of window defects in the early and the late phases, whereas when we see the ICG angiography, there was more of mid-phase choroidal hyperfluorescence with absence of any network or polyps that were at this stage. So I came to a working diagnosis of CSCR and started the patient on oral eplerenone and topical neparfenac drops. Over the next 2 months, there was a good reduction in the subretinal fluid with an improvement in the visual acuity up to 6 by 18. Now, unfortunately, the patient came 3 months later with a worsening of the subretinal fluid and the visual acuity dropping to 6 by 60. Now, at this stage, the flat irregular PED had actually increased. So, I repeated an angiography again at this stage. The ICG showed a very similar picture. There was a very suspicious network at this stage, but which was not very much visible on ICG. And so, at this stage, I did an OCTA. So there was a faint network that was visible at the posterior pole, and hence I came to a diagnosis of a pachychoroid neovasculopathy at this stage. And this is a multimodal imaging showing at this stage. So this is the zoomed in image of the ICG. A very faint network is visible, and this is the corresponding OCT of the patient. So for this patient, I did a full fluence photodynamic therapy along with intravitreal ranibizumab, and 1 month later there was a complete resolution of the fluid on OCT, and the network had completely resolved on the OCT angio. However, again after 3 months, the patient's visual acuity was stable, but OCT angio showed a recurrence of the network, but there was absence of any OCT biomarker of disease activity. So I have been observing the patient, and even at 1.5 years, the patient's visual acuity gradually improved up to 6 by 18. The network is increasing in size, but still absence of any OCT biomarker of any disease activity. So just few points of discussion. There was CNVM missed at baseline, and there was an improvement on conservative management. So was it just a CSR at baseline which then converted to a neovasculopathy? And should OCTA be done for all suspected networks? And if we do not have access to OCTA, what are the OCT biomarkers that may give us a hint into an early identification of an early network? And if there's a quiescent network, what should be the way forward? So I think Anirudh, should I go ahead with the second case or should we just discuss? Okay. So this is a second case. This is a 64-year-old male who came with reduction of vision in the right eye since 1 week. His visual acuity was 6 by 45 and 36 in the right eye and 66 and 6 in the left eye. Now the right eye showed presence of a large pigment epithelial detachment in foveal region and another in the peripapillary area. And in the left eye there was presence of pigmentary changes just inferior to the fovea and track marks that were seen temporally. Now, if we see the OCT of the right eye, there was a presence of an extra large pigment epithelial detachment, and the Brooks membrane was not visible. I think that is most probably because of the large size of the PED rather than considering a hemorrhagic PED kind of feature. And there was an area of RP thinning that was there superior-temporal to the area of the fovea, and this is the another peripapillary PED that was there. If we look at the other eye, the foveal section was normal, but there was kind of an RP aperture inferior to the foveal area with presence of an intraretinal fluid. Now this is the autofluorescence of the patient. There was a hypoautofluorescence at the posterior pole in the right eye that corresponded to the area of the PED, and another dense hypoautofluorescence that was present that probably corresponded to the area of the RP thinning. And in the left eye, the track marks are visible on the autofluorescence image, along with a dense hypo corresponding to the area of absence of the RPE. Now this is the angiographic image of the right eye. Now on fluorescein angiography, there was pooling of the dye that corresponded to the areas of the pigment epithelial detachment, and a staining was seen corresponding to the area of the RPE thinning in the right eye. The ICG showed hypocyanescence corresponding to the large area of PED, and an area of hypercyanescence that corresponded to the area of the RPE thinning. Now this is the multimodal imaging of the left eye. And on fluorescein angiography, again there was staining present in corresponding to the area of the RP loss, and along with that track marks were visible temporally, and the ICG did not show much significant changes. So was it just an occult CNVM or was it just an extra large PED? So I went ahead and gave one dose of injection of ranibizumab since the patient was very symptomatic. Now unfortunately, after a month the patient had significant worsening of the vision, and vision acuity dropped to counting fingers 3 meters. If we look at the corresponding IR image, the PED size had massively increased and covering the entire pole to pole, and there was presence of IRF and SRF at this stage. So in view of the drop in the visual acuity with a massive increase in size of the PED, I switched the patient to aflibercept. Now thankfully the patient responded very well to aflibercept, and after a month his visual acuity improved to 6/18 and 10. There was almost near total collapse of the PED and dissolution of the intraretinal fluid with presence of an early focal choroidal excavation at the posterior pole. And when I went through the scans, as I think Atul sir correctly pointed out, it's very important for us to actually go and visit the imaging room and look at all the sections and not just sections what our technician may upload. So there was presence of an RP rip that corresponded to the area of the RP thinning that was there pre-injection stage. Now the patient received 2 more doses of aflibercept, and at the end of 3 months, his visual acuity improved to 6/9 parts with almost complete absence of fluid at the posterior pole, and there was very mild SRF that was present temporarily, and I was just observed the patient at this stage. Corresponding to the area where there was RP loss, there was a proliferation had happened and the RP defect was covered. So for this patient, the few points for discussion was the treatment actually needed at baseline, which regimen and molecule is ideal for this patient, and should we continue injecting even after we develop an RP rip? Thank you.
Thank you, Jay. Any
I think most probably it could be a CSR with a PED. I couldn't see any network. Unfortunately, I have not done a imaging after the PED had collapsed completely. Or there could be an underlying occultation. That would be my second differential.
any comments?
Okay.
There are, I mean, this can have a discussion of half an hour also. It would have been good if the way of presentation is show one image and ask the panelists and audience what now.
Hmm.
Because once you have some features later on, then you can guess now what would have been there
Yeah.
time. But these are always challenging that if you have such large PEDs, you are not sure whether or not.
True.
You don't treat, patient comes back, say the doctor made a wrong diagnosis. But if you treat and still the patient develops hemorrhage, because it's not absolutely necessary that with treatment everything will be like this. Actually, the rip is the reason why suddenly if you have
Suddenly there was a collapse.
it flattens like this, it's very with brolucizumab maybe we are seeing some cases, but otherwise you must suspect a rip which has reduced the tension and
The flattened.
either way it's always a second. These cases are extremely challenging with such PEDs. I would not say at this time that you should have injection early itself and it should have saved something. But fortunately for this patient, did not affect the central macula. And as Dr. Atul pointed out, yeah, if the pathology is still there, you still need to treat.
So would you treat at baseline, and what would be the molecule that you would have preferred at presentation for the patient?
Yeah, in this patient, since the patient was symptomatic,
Hmm.
time I prefer brolucizumab in these
Okay.
cases. Although I don't have too much experience, the bleeding can still happen even with that. If you are looking to treat the PED, yes, it's a better molecule.
Okay.
It has a better penetration.
True. Any other comments or questions?
Hello, hello.
Yeah. Okay. Thank you.